Hello, everyone. Good morning. We are starting our third session here today. And okay, I had to turn off some tabs in my computer so that it would be better. Okay, so last time we did these things. Let me repeat it. Okay, can anybody hear me? Can you hear me? Let me see if somebody replies. Hello, can you hear me? Can you please reply on YouTube or join it? Anyway, last week we did the optic eye lesions, the lesion in the eye, optic tract lesion, and the lesion in the optic nerve before the optic chiasma that causes complete blindness, and an incomplete lesion causes, if it's in the temporal fiber, causes nasal blindness, like this here. And a lesion in the optic tract causes blindness in the opposite half of both eyes. So a lesion in the right optic tract causes blindness in the left half of both eyes, like here, homonymous hemianopia. And a lesion in the optic chiasma causes bitemporal hemianopia, like this, that is heteronymous hemianopia. Then we did, so this is homonymous hemianopia, the right optic tract lesion causing blindness in the left eye, and the left one causing blindness in the right eye. Then we did the pupillary light reflex, and then we did the fundoscopy, normal findings, macula. This is everything about that. And the optic cup, the neuroretinal rim, optic disc, and then we did the neuroretinal rim. This is central the optic cup, blind spot, and this bigger circle is the neuroretinal rim with the features that whenever cupping occurs, the rim atrophies, and the features of the cupping was that the cup enlarges in size, there is nasalization of the blood vessel, there is a notch, and there are splinter hemorrhages. And then we did, let me see, then we did the papilledema, its clinical features, its stages. Stage 1, we have incomplete C-shaped grayish halo. Then stage 2 is the complete grayish halo. Then stage 3, obscuration, partial obscuration of a blood vessel, leaving the optic disc, and stage 4, complete obscuration of the blood vessel, leaving the optic disc, and then stage 5 we have dome-shaped elevation of the optic cup, and then we had also star macula, which occurs in neuroretinitis, but also in papilledema, diabetes, and hypertensive retinopathy. And then we did the features in the uh, papilledema. Let's see, and investigations, lumbar puncture, B scan, fluorescent angiography, fundus autofluorescence, optical coherence tomography, and MRI features. MRI is more important because it detects the changes before they appear on the ophthalmoscopy. And then what we did, pseudopapilledema. This is pseudopapilledema. Compared it with the papilledema heat down here, because in pseudopapilledema these margins are clear. There's elevation but no swelling of the disc. and it's chalky white. This one example is AMD, and these are drusen they deposit under the pigment epithelium. And then we compared this papilledema with this pseudopapilledema, the blood margin, elevation, everything, and then pseudotumor cerebri, where there is increase in the pressure and the um, optic disc edema, papilledema, plus increase in intracranial pressure, but there is no other findings in the increase in intracranial hypertension or pseudocoronary hypertension. And then we did the hypertensive retinopathy, then stages, mild, moderate, severe, and the stage 4 was grade 4, grade 3 plus papilledema in the hypertensive retinopathy, and in the severe hypertensive retinopathy we see microorganism hemorrhages, cotton wool hemorrhages, and and then we did the vascular stages in the hypertensive retinopathy. This is papilledema. These are the vascular changes in hypertensive retinopathy, narrowing. Then we had this AV nipping in the second stage. Then the venule looks detached with the proximal part, and then copper wire and the silver wire in the last session. Then we did the diabetic retinopathy, non-proliferative and proliferative, mild, moderate, severe. That follows severe follows the rule of 4 to 1, and a proliferative VG ischemia. We see proliferation due to VEGF. And then let's see, the stage 2, 4 of the 4 to 1 is venous bleeding. And what's venous bleeding? Venous bleeding is the irregular constrictions and dilatations of the venules in the retina. So let's see what we did. Where's my disappeared? Okay. And now let's go back. Let me see the page. Okay, and then Irma's interretinal microvascular abnormalities, at least in one quadrant in diabetes. Then this is the proliferative form of diabetes due to the production of VEGF by ischemic retina. And then diabetes control at different sugar levels with the insulin and anti-VEGF drugs. Okay, and then metformin, and now we go to the blood supply of the optic nerve. Now we start today here. So this is the optic nerve that runs from front to the back to the occipital cortex, the area 17. So it has different blood supply in its course. And let's discuss the blood supply of the front optic disc and the optic nerve head and front of the optic nerve. The front of the optic nerve is supplied by the ophthalmic artery, which is a branch of the internal carotid. Ophthalmic artery gives two branches here, the central retinal artery and the ciliary retinal artery that supply the optic nerve. So the central retinal artery, it arises from the ophthalmic artery and it pierces the optic nerve about 10 millimeter behind the eyeball and runs in the substance of the optic nerve and divides the middle two-thirds of the retina. The anterior two-thirds is supplied by the ciliary arteries, and this central retinal artery also supplies the optic nerve head. So let's see. Internal carotid, ophthalmic arising from the internal carotid, and then it divides into two, central retinal artery and the ciliary arteries. And then it's the optic nerve head blood supply is by anteriorly by the short posterior artery, circle of Zinhaler, pial, choroidal, and collateral branches of ophthalmic and others. And distal part of the optic nerve head is supplied by the branches of the central retinal artery. So these posterior ciliary artery, they give rise to the short ciliary artery, which pierces the sclera. They also give choroidal, and they supply the optic nerve head anteriorly. So what happens if the central retinal artery is blocked? If it causes acute painless blindness, sudden painless blindness, and it supplies the middle two-thirds of the retina, so it becomes like this, with the appearance of a cherry red spot. And if the ophthalmic artery is blocked, which is the main artery, so both the total blood supply to the eyeball is obstructed, or to the retina and to the optic nerve is obstructed. So that causes more severe blindness with the no appearance of the cherry red spot. So absence of cherry red spot is an ominous sign. And then we have the central retinal vein obstruction that also causes sudden painless monoocular blindness and follows the Virchow's rule, vessel damage, stasis, and hypercoagulability. And this causes brain stroke also because the blood clot formation. And then we have the blood supply to the posterior part of the optic nerve over here, just behind the optic disc. This is prelaminal, laminal, and postlaminal area. So what's lamina? This is lamina. Lamina cribrosa, which is a mesh-like gelatinous structure through which the axons of the ganglion cell layer pass pass along with the other blood vessel and other fibers. So this lamina cribrosa gives supports, number one, and number two, the optic nerve fiber up to the lamina cribrosa are unmyelinated. See here, this is the lamina cribrosa. So before this is 1 millimeter area that the nerve fibers are unmyelinated. That is why the multiple sclerosis causes retrobulbar neuritis, because it acquires the myelin sheet or white matter after the lamina cribrosa. So the prelaminar portion is supplied by circle of Zinn and choroidal arteries. Laminar zone is supplied by the short posterior ciliary and pial arteries, and a postlaminar zone is supplied by the pial arteries. These are the pial arteries supplying in the back portion. The short ciliary arteries also give rise to ciliaretinal artery. So this is the circle of Zinn here, and this is the pial arteries in the back portion of the nerve. Circle of Zinn in the prelaminar area and also to the optic nerve head. And then we have other causes of cherry red spot that appears in the central retinal artery obstruction. The cherry red spot may appear in storage diseases and certain drugs and chemicals. So these are the diseases: Tay-Sachs, Niemann-Pick, sialidosis, and metachromatic leukodystrophy. So these Tay-Sachs is due to the deficiency. These diseases are due to deficiencies of the enzymes. So Tay-Sachs is due to deficiency of the galactosidase, and gangliosides accumulates. Sphingomyelin deficiency occurs in Niemann-Pick disease and sphingomyelin deposits. Similarly, aryl sulfatase A deficiency causes metachromatic leukodystrophy, the dystrophy of the white matter that causes progressive muscular and mental changes and decline in the function and peripheral neuropathy. Okay, and then the drugs that cause The cherry spots are MCQD, methanol, carbon monoxide, quinidine, and dapsone. So methanol is taken accidentally for ethanol, and very small amount can cause blindness. It causes bilateral visual loss in 48 hours after the consumption with dilated fixed pupil. And what's the toxic metabolite in methanol poisoning is formaldehyde and formic acid, and the antidote is ethanol and fompizole. The carbon monoxide is a colorless, odorless, smellless gas. Carbon monoxide combines with hemoglobin to form carboxyhemoglobin. It displaces oxygen from hemoglobin and has an affinity 200 times more than oxygen for the hemoglobin. So it causes ischemia and anoxia of the neurons and optic nerve, causing blindness. Otherwise, it also causes confusion, disorientation, neurological damage, coma, and death, and encephalopathy in delayed stages. The treatment is maybe early stage hydroxycobalamin or 100% hyperbaric oxygen. And now this is the optic chiasma. Here the blood supply is by the by the circle of Willis. This is optic chiasma here, and above this is the circle of Willis formed by these blood vessel internal carotid giving middle cerebral, then anterior communicating, then posterior communicating. Posterior communicating, where does it arises? It arises from the basilar arteries, and basilar is formed by the union of the two vertebral arteries which pass through the upper six cervical uh, vertebral foramina, pass through the foramen magnum to form the basilar, which divides into two posterior cerebral arteries. So this is the structure above this. So what is structure below the optic chiasma? Remember that's pituitary glands in the sella tracheica bone of the sphenoid. This is pituitary here, and then optic chiasma, and then not shown here is the circle of Willis, and then is the hypothalamus, and then see this picture here. Then is this the pituitary in the sella tracheica of sphenoid. Then this is the optic chiasma, then hypothalamus, and the ventricle, third and fourth ventricles, and the lateral ventricle above that. And this pituitary has on its side has an important structure. This is known as cavernous sinus, and the cavernous sinus thrombosis is a medical emergency. So in the content we see in the lateral wall, third, fourth, fifth nerves. The first two branches of the fifth nerve, ophthalmic and maxillary division, and the third nerve and the fourth nerve, the trochlear that supply the superior oblique. And then in the middle we have this abducent nerve, and this is the internal carotid artery with its sympathetic plexus surround that. So these are the midline structure in the midline, but another important structure posteriorly, but in the midline between the two cerebral hemisphere is this is pineal gland. Pineal is important. It's in between the groove between the two cerebral hemispheres by the superior colliculus. So pineal it calcifies in the young age around 20 and is visible on plain X-ray of the abdomen of the skull. See, this is the pineal calcified here, and this is a pineal tumor. It presses on the superior colliculus and causing Perinaut syndrome. Perinaut syndrome, we have a video. Anybody wants, I can watch it. So this pineal in the early ages produces melatonin and other from serotonin, and if there is penelectomy or its tumor may also block the cerebral aqueduct, causing uh, hydrocephalus, non-communicating, of course. Then we have pineal tumor. Then it is pinealectomy in children may cause increased production of FSH and LH that leads to increased accelerate the development of sexual organs and skeleton. Now, the next topic is optic atrophy. Let's see. Need a break for a second. Okay, let's see what somebody. Okay, need a break. Okay, the next topic is optic atrophy. So, the optic atrophy cannot be reversed, there's no treatment, and it's a permanent visual loss. Unilateral lesions cause are anterior to the optic chiasm. Most common cause of optic atrophy is a vascular cause, anterior ischemic optic neuropathy. So the optic atrophy may be primary or a secondary optic atrophy, or it may be anterograde or retrograde, or it may be glaucomatous optic atrophy is a little different. So we'll discuss that one too. So this is the primary optic atrophy here. You see the chalky white optic cup, and this is the clear margins, very little optic cupping, and the blood vessels are normal. So this is the primary optic atrophy. Compare it with the secondary optic atrophy. This is the second, as seen in papilledema. The discolored optic disc margins are not clear. There are hemorrhages, and it's raised above the surface. So all the features of papilledema we discussed in that. Compare this primary optic atrophy that occur due to optic neuritis, right? And anterior ischemic optic neuropathy. And this is the papilledema. And the causes of the secondary optic neuritis, we saw that causes a tumor, also vascular causes, and papilledema. Whereas the causes of the primary optic neuropathy are AION, anterior ischemic optic neuropathy, trauma, tumor toxins, or drugs may also cause the primary optic atrophy and the autoimmune disorder like multiple sclerosis and degeneration. Congenital causes, liver atrophy, and autosomal dominant, they may cause primary optic atrophy. Now, chemicals and drugs that cause optic atrophy are ACDE2M. A for amiodarone, C for ciprofloxacin, D for digitalis, E for ethambutol or ethylene glycol, and methanol. These two, methanol and ethylene glycol, cause acute blindness, acute optic atrophy. And ethambutol causes slow, progressive, bilateral, gradual visual loss. So let's discuss methanol. We already discussed its toxic metabolite is formic acid and formaldehyde and causes bilateral blindness. Whereas ethylene glycol, let me see what do we have here. Ethylene glycol, it, it's used as an antifreeze and causes cerebral edema with bilateral visual loss acutely. Its toxic metabolite is glycolic acid, and the treatment is same as that of methanol, that is ethanol and a fompazole. So this is the comparison between the three substances and their end product. Ethanol produces acetyl CoA, methanol produces toxic formic acid and formaldehyde, and ethylene glycol produces glycolic acid, which is converted into glyoxylic acid. So it's a funny question here. What's the difference between ethylene glycol and polyethylene glycol 3350? Polyethylene glycol is a laxative. It's not absorbed. It causes osmotic um, effects on the intestine, producing stools. Then the ethamol toxicity. Ethamol is an anti-tubercular drug used, and it's toxic for the uh, retinal ganglion cell layers, and it causes bilateral visual loss with secocentral or central scotomas. See this? They are produced by this because this is toxic thinning of the retinal nerve fiber layers, RNFL. So the toxicity is reversible, but it may be permanent. So discontinuation of the drug should be done, and this toxicity occurs about 3 months after the starting the treatment, and the eye examination is recommended every 3 months. And it's which vitamin is effective in preventing it? That's vitamin B6, pyridoxine phosphate prevents. And the next drug is amiodarone that is deposited in the cornea. And then tobacco also causes slowly progressive painless visual loss bilaterally. Then we have anterograde optic atrophy or Valerian degeneration. In this anterograde degeneration, there is degeneration from retina to the lateral geniculate body. The other one is retrograde degeneration, is proximal portion of the axon to the optic disc. Then we have glaucomatous optic atrophy. It has some changes of both. Serous margins are clear, and there is cupping occurs superiorly here more, and the blood vessels there is naturalization. There is what is called the nasalization of the blood vessels. So features of the papilledema, but otherwise the margins are very clear, and there is backward bowing of lamina cribrosa. So this was optic atrophy. Now we go to the optic neuropathy and optic neuritis. Okay, now we'll move on to the optic neuropathy and optic neuritis. And let's see. Okay, any condition that affects the optic nerve is optic neuropathy. And most common cause of okay. And then we have okay, then we have let's see. A most common cause of optic neuropathy neuritis is ION, ischemic optic neuropathy. And causes of the optic neuritis are infections, bacterial, Lyme disease, syphilis, and cat scratch fever. Okay. Where's my StreamYard? Okay, I lost it. This is not the StreamYard. I lost the screen. So the StreamYard. Okay, now let's go. We did the bacterial, now viruses, mumps, measles, herpes, cytomegalovirus. And then we have immune disorders, multiple sclerosis, vascular causes, ischemic optic neuropathy, tumors, vitamin B12 deficiency, pernicious anemia is a common cause of vitamin B12 deficiency. Also, gastrectomy causes it. Low serum protein, protein deficiency, radiotherapy, genetic liver atrophy, and there occur neuritis, that is scarmacula. So that's in the optic neuropathy here, we already discussed. Then optic neuritis types, typical and atypical. Typical optic neuritis is painful and unilateral. Atypical optic neuritis is painless and bilateral. Typical causes mild disc edema without exudates and hemorrhages, while atypical causes severe exudates with or without hemorrhages. The typical one improves after 3 months, and the atypical one continues worsening over the month, and steroid withdrawal. There is no relapse of the typical optic neuritis, but relapse occur after steroid withdrawal with atypical optic neuritis. Then let's discuss the multiple sclerosis. That is a cause of uh, optic neuritis. It may be unilateral, but may also be bilateral. But commonly, usually, it's unilateral with central scotoma. So this is due to multiple sclerosis is an autoimmune disorder with T cell activation followed by B cell activation that produce antibodies that cause attack the white matter, the myelin sheath. So the attacks are waxing and waning. They attack the different parts at different times. So healing also occurs, and healing occurs. What causes the healing? It's the oligodendrocyte that causes the healing. The patient complains of the pain with eye movement, and the neuritis is retrobulbar. It's said that EB virus also may trigger the multiple sclerosis. Epstein-Barr virus may trigger oligodendrocytes produce myelin, damage repairing cells, and about 25 to 30% of the patient of multiple sclerosis develop optic neuritis at some time. Okay, then we come to the abnormal pupillary light reflex, and in this we'll discuss two, the Marcus Gunn and Argyll Robertson pupil. So in the Marcus Gunn pupil, which is very important in retrobulbar neuritis, which occur in multiple sclerosis, normally in the normal pupillary light reflex, when the light is thrown here at the pupil constrict, and in the other one also constrict, which is known as consensual light reflex. But here, because of the neuritis, when the light is thrown, it causes slow sustained contraction followed by the slow dilatation in this eye, affected eye. And what about the other eye? The other eye, consensual light reflex is normal. And then if the light is thrown here in the unaffected eye, its pupil constrict normally, constriction is normal, and the consensual light reflex in the other side, on the affected side, is also normal because the motor part is by the oculomotor nerve that brings the pupillary light reflex to the affected eye. So in that, optic nerve is not concerned. Then we do the Argyll-Robertson pupil. Argyll-Robertson pupil, in which light reflex is absent and accommodation reflex is present. ARP, accommodation reflex is present. The light reflex, it has three parts. The this accommodation reflex, I'll discuss it later. So the light reflex is absent. Why is it absent? Because it, it usually it occurs in the syphilis or diabetes and other vernix encephalopathy or any other condition or tumor. that affects this part of the midbrain that disconnects the communication between the midbrain and the Edinger-Westphal nucleus, which is bilaterally connected to this. So in this case, the pupil is bilaterally irregular. It's slightly constricted and difficult to dilate. So this pupillary light reflex is absent in Argyll-Robertson pupil. But accommodation reflex is present. Why is it so? Because accommodation reflex is not controlled by here. It's controlled by centrally. So this optic nerve here goes straight from the lateral geniculate body through the geniculocalcrine tract to the area 17 of the occipital cortex, the visual cortex and the association area 18, 19. So from here, this part, let me show you. This part, visual cortex, is connected to the frontal eye field area 8, which is in the frontal lobe, in the superior frontal gyrus. Here it is. Frontal eye field controls the eye movements and head movements also. And this is connected through this. This is known as superior longitudinal fasciculus. So superior longitudinal fasciculus connects the visual cortex to the frontal eye field area 8 in the frontal lobe. So let's see here. This is frontal lobe. And that and that sorry about the interruption. And then we have, I was telling about, this is the let's see. No, I misplaced somewhere. Okay. So this is the area 8, frontal eye field, in front of the, and this is in the frontal lobe in front of the motor association. This is motor area, and this is central sulcus. Behind us is 312 area, sensory cortex. So it's in front of the area 6, the motor association area. So how is it connected and how it controls the eye movements? So this is here the frontal eye field, area 8. It's connected to many parts of the brain, to the cerebellum, to the sensory cortex, to the basal ganglia, to the substantia nigra, caudate nucleus, to the superior colliculus, and finally to the pons, and in the pons to the PPRF, paramedian pontine reticular formation. So this is the connection between them. The visual cortex to the visual association area, all this connected through the superior longitudinal fasciculus. Let me enlarge it a little bit. Through the superior longitudinal fasciculus to the frontal eye field, area 8 of the opposite side here. And this frontal eye field area is connected on the opposite side to the PPRF, prepontine reticular formation, PPRF, in the pons, right? And then this PPRF is connected to the ipsilateral CN6 nucleus, the abducens nucleus. Then this abducens nucleus is contralaterally connected to the oculomotor nucleus that supplies the medial rectus through the medial longitudinal fasciculus to the opposite side. So this frontal eye field here on the right side is controlling indirectly the right side of the oculomotor nucleus that supplies the medial rectus. So this is a little complicated connection, but important to know. So from visual let me see that picture here. Let's see here. This is the frontal eye field is connected to the This is PPRF and then PPRF to the ipsilateral abducent nucleus that supplies the lateral rectus ipsilaterally. And then this is also connected through MLF, medial longitudinal fasciculus, to the third nerve nucleus, to the medial rectus muscle. Here also, this is frontal eye field area 8. And if you follow the orange line, it's connected to the PPRF here, PPRF to the abducens nucleus, to the lateral rectus ipsilaterally, and contralaterally to the medial rectus nucleus, oculomotor nucleus, to the medial rectus muscle. So this was it. And then lesions of the frontal eye field may be irritative lesions like a epileptic focus or a destructive lesion. So what do they cause? An irritative lesions of the frontal eye field causes conjugate movements of the eye to the opposite side. Conjugate gaze lateral, contralateral to the stimulation, to the looking away from the lesion. And, and a destruction causes conjugate gaze towards the lesion, deviation to the ipsilateral side, looking at the lesion. Then we have ADS people. If you want, I can, but it's a defect in the third nerve, ciliary ganglion. So that's it for the day, and then we'll do this blindness in the next one. If there is a somebody question, they can ask me or join the field, so we can do that. So we did all these things today, and hopefully next time see you, so that it will be the end. Or maybe next time we do the some endocrine thing like pituitary gland probably. Okay then, no questions. So we leave now. Bye.